And we are beginning this morning's programming with a presentation. CRAN, in collaboration with multiple patient group partners, led a national pan-tumour survey to better understand how well current systems are meeting the needs of younger adults diagnosed with cancer. The ultimate goal of this initiative was to investigate the question, are early age onset cancer patients' needs being addressed? The findings offer critical insight into where the gaps exist in treatment and survivorship, and I believe they truly reinforce the urgent need for tailored multidisciplinary support. This presentation will be delivered by Shalini Gambier, CRAN's Research Officer, Filomena Servideo Italiano, CRAN's President and CEO, and myself. And with that, I'm very pleased to hand it over to my colleague Shalini, who has worked tirelessly to engage patient partners, disseminate the survey, and analyze and present the data. Over to you, Shalini.
Thank you so much, Cassandra. Good morning, everyone, and thank you so much for joining the session today. Today, we'll be walking you through our research findings on understanding access to multidisciplinary care and support needs during treatment and survivorship. The presentation focuses on findings from our 2025 National Early Age Onset Cancer Pan-Tumour Patient Survey, aimed at capturing how younger adults across Canada are experiencing cancer care from diagnosis through survivorship, and whether current systems are meeting their medical, psychosocial, and supportive care needs. Our goal today is to share the key patterns and insights emerging from this dataset, highlight areas where system strengthening is needed, and set the stage for ongoing discussions about optimizing care models for this growing patient population. To provide a clear sense of the flow, we've organized the presentation into 4 key sections. We'll start off by outlining the purpose of the survey, who was involved, and how the data was collected. Next, we'll walk you through the demographic characteristics of the respondents. However, the core of the presentation will focus on patient care experiences, both among those who accessed young adult cancer programs or clinics and those who did not, along with the unmet needs that emerge across that cancer journey. We'll conclude with key implications and priority area systems for system improvement. Together, these sections will offer a comprehensive review of how younger adults experience cancer care in Canada and where the system must evolve to better meet their needs. All right, so to ground the findings that follow, I'll begin by briefly outlining the purpose of the survey, who contributed their perspective, and the approach we used to generate the results you'll see today. I'd like to begin by sharing the 2 core objectives that guided this survey. First, we sought to characterize the clinical, psychosocial, and supportive care needs of adults diagnosed with early age onset cancer across both treatment and survivorship, with a focus on identifying gaps that meaningfully influence patient experience and access to quality care. Second, we evaluated patient access, utilization, and experiences with multidisciplinary young adult cancer clinics or programs across Canada. We surveyed 143 patients in Canada, all of whom met specifically eligibility criteria to ensure the data reflected meaningful experiences. Respondents were required to be Canadian patients or survivors diagnosed with cancer between the ages of 18 to 49 and to have received care within the Canadian health system. Caregivers were also able to respond on behalf of patients when necessary. As we move through the findings, you'll see that the sample size varies slightly across different questions. This is due to responses that were either skipped or marked not applicable and were excluded from the reported totals to maintain data integrity. So a national survey was conducted between August 19th and October 14th of 2025 using SurveyMonkey as the hosting platform. Respondents completed an online questionnaire consisting of up to 39 multiple choice and open-ended questions. To ensure broad national reach, we used a multi-channel dissemination approach. The survey was shared through CRAN's email lists and social media platforms, as well as through 21 patient groups across Canada, helping us capture perspectives across diverse tumor types and provinces. I'd like to take a moment here to extend CRAN's sincere appreciation to the 21 patient groups whose support enabled the dissemination of the 2025 National Pan-Tumour Patient Survey. Their dedication has been truly invaluable. To ensure consistent interpretation across respondents, we included a standardized set of definitions. This helped clarify the distinction between the adolescent and young adult programs dedicated for patients 15 to 39, as opposed to early age onset cancer clinics dedicated for patients 18 to 49, both of which rely on multidisciplinary integrated support models. Also referenced were survivorship and survivorship care plans. Turning now to the demographic profile of respondents, this data provides important context for interpreting the clinical, psychosocial, and survivorship findings that follow. We'll first examine geographic representation to understand where respondents were receiving care. We are pleased to receive representation from all provinces across Canada, offering a meaningful national perspective. The largest proportion came from Ontario at 38%, followed by British Columbia at 20%, and Alberta at 14%. Notably, none of the territories were represented. This distribution reflects both population density and the location of major cancer centers, but it also highlights the importance of capturing experiences from smaller provinces and rural regions where access challenges can be more pronounced. We now shift to the diversity of tumor types represented. The largest groups were breast and colorectal cancer, together accounting for more than 60% of respondents. Blood cancers formed the next largest category, followed by gastrointestinal tumors and thoracic cancers. Smaller tumor types, though fewer in number, still offer meaningful insight given the wide variation in treatment trajectories and follow-up needs across early age onset cancers. This distribution is consistent with national trends, showing rising incidence in adults under 50. Disease severity was also notable. Nearly one-third reported stage 4 diagnoses and another 22% at stage 3, underscoring persistent delays in detection. So building on this clinical profile, we now turn to age and gender. The age distribution skews toward the older end of the early age onset spectrum. 53% are currently 41 to 50 years of age, with another 20% now at 51 to 60. These figures reflect current age, not age at diagnosis. More revealing is age at diagnosis. 63% were diagnosed in their 40s and 34% in their 30s, mirroring rising incidence of older adult cancers in younger populations. These life stages carry major employment, parenting, financial, and reproductive responsibilities, amplifying long-term impacts. We see a clear education level bias here illustrated in this slide. The majority of respondents held post-secondary credentials, with the largest segment reporting an undergraduate degree at 31%, followed by graduate level training. This higher socioeconomic profile is important context, as it often correlates with greater health literacy and self-advocacy. Yet unmet needs emerged consistently across the survey, suggesting that structural barriers, not individual capacity, drive many gaps. Employment data reveal the degree of disruption caused by cancer at this life stage. 37% respondents were not working at the time of the survey. Among those employed, 49% worked full-time and 8% part-time. These figures highlight that the significant economic strain experienced by younger adults, many of whom were in the peak of their working years at diagnosis. Here we address structural access, a key determinant of treatment continuity. Most respondents reported reliable or convenient transportation, with another 36% calling it usually reliable, leaving about 8% experiencing inconsistent access, an important barrier for time-sensitive care. Travel time adds another nuance. While most travel under an hour, roughly 15% commute more than an hour each way. Qualitative comments show that although local care was nearby, specialized services often required 1 to 2 hours of travel. These patterns highlight fragmented access and persistent geographic inequities, with younger adults in rural or semi-urban regions facing limited availability and higher out-of-pocket costs. We'll now turn our attention to younger adults' real-world experiences within cancer care system. We'll look at what they encountered across their care journey, what needs remained unmet, and how access to a dedicated young adult cancer clinic shaped their overall experience. The remainder of this section will be led by my colleague, Cassandra McCulley, Chief Research Officer here at CRAN and also our symposium moderator. I'll now pass it over to her to walk us through this section.
Thank you so much, Shalini. Thank you for setting the stage so nicely for me there. So let's start this section with one of the most startling, though unsurprising, findings from the survey. 83% of younger adults reported having no access to a dedicated young adult cancer clinic. For a population with well-documented, age-specific clinical and psychological needs, this represents a profound system-level gap. Among the 17% who did have access, most were seen in AYA clinics, with a smaller proportion in early age onset specific clinics. Importantly, when these clinics were available, patients did engage and they did utilize them. Half of respondents reported utilizing services regularly, and another 35% used them occasionally. The limited number of patients who are ultimately cared for in these specialized clinics seems not to be a reflection of disengagement or patient preference, but rather a fundamental issue of system design and availability. And it's representative of, I think, a structural gap in our cancer care system. As we examine how younger adults enter specialized models of care, the referral patterns reveal considerable variability. Only 29% of referrals originated from oncologists, the clinicians really most positioned to recognize age-specific needs. The reminder came through other healthcare providers, such as social workers or nurses, or non-specific routes, underscoring the absence of a standardized referral process for young adult oncology. Among those who did not access a clinic, roughly 2/3 reported being unaware that these clinics or programs existed, and they noted that they were never referred by their healthcare teams. As we turn to points of care, most patients, so 65%, access the AYA or early age onset clinic at their primary cancer center. However, nearly 1/3 access services virtually or through telehealth, with additional patients receiving care at different cancer centers. Together, these patterns point to a significant geographic equity gap. Access to age-appropriate care is closely linked to where a patient lives. We heard Katie speak about this in the introduction today, and the resources that are available within their local cancer center. On the other hand, the use of virtual modalities is telling of a potential opportunity to expand virtual components of young adult cancer care, particularly for jurisdictions without specialized programs. Overall, the data here signals the need for greater standardized referral pathways and more equitable, geographically agnostic, and accessible models of care. Shifting to supportive care, this slide highlights both the availability and the uptake of key services within specialized AYA or early age onset clinics. What stands out immediately is the consistency with which mental health and nutrition support are used. Both were utilized by every respondent who reported having access, underscoring their central role in young adult oncology. Supports related to employment, education, finances, physical rehabilitation, and parenting are far less accessible. These gaps mirror some of the highest burden unmet needs reported in the survey, indicating that younger adults are routinely left without the resources required to maintain stability during and after treatment. Here we're highlighting the key supportive care gaps reported even among the patients who did have access to a specialized model of care. This is important because it allows us to examine limitations and, more importantly, opportunities for improvement within established models of care. Support related to fear of relapse was the most frequently reported unmet need, reported by 65% of respondents, underscoring the lack of embedded longitudinal psychosocial follow-up within many clinics. Employment, education, and financial concerns followed closely at 53%. As we saw in the previous slide, these services were only actually available to 18% of respondents who were treated in specialized clinics, pointing to limited availability, capacity constraints, or perhaps insufficient referral integration. Side effect and pain management, as well as rehab, also emerged as significant gaps, indicating again that survivorship and functional recovery needs are not yet consistently addressed within these models of care. Notably, mental health services do not appear in the top categories here, but qualitative feedback made their limitations clear. Patients cited long wait times, session caps, and lack of continuity. This explains how mental health care can be widely utilized, yet remain substantively inadequate. Overall, I think these findings complement the previous data and remind us that availability doesn't necessarily ensure adequacy. Remember as well that these gaps are being reported by patients accessing multidisciplinary care tailored to young adults, likely at some of the top cancer centers in our country, and we're still seeing some significant opportunities for improvement. So as we move into the next section here, we'll examine how patient experiences differ depending on the model of care patients were supported by. This comparison allows us to identify which elements of care are driving better patient experiences and where traditional approaches may fall short. So let's examine how these two models kind of translate into practice. So the top unmet needs reported by patients who were treated in traditional models of care, so without access to multidisciplinary, age-appropriate care. The top unmet needs were mental health support at 53%, nutrition support at 46%, and fertility and sexual health counseling at 31%. So what's really interesting here is if you recall the data that I shared earlier, the top services that were actually utilized by patients who had access to specialized young adult cancer clinics were mental health, nutrition, and fertility, the exact same as the unmet needs identified by those without access. This consistency shows that young adults have well-defined and predictable supportive care priorities and needs. The difference lies in whether the system enables those needs to be met. Specialized clinics are structured to deliver these services. Traditional models are not. As a result, identical needs manifest as uptake in one model and unmet need in another. This divergence underscores why dedicated AYA and early age onset clinics matter. They provide the mechanisms and the coordination required to translate known patient priorities into actual care. And without clinic access, these priorities become critical gaps in care. So as we move from supportive care needs to the practical realities of navigating treatment, clear divergences continue to emerge between the two models of care. Those without access to a clinic reported higher rates of long wait times and felt more socially isolated during treatment. The no challenges metric is particularly telling. So only 13% of patients in traditional models of care reported that they did not have any challenges while receiving care. And that compares to 36% in specialized models. This difference indicates that specialized clinics help identify and they help intervene on issues that would otherwise go unrecognized in standard oncology settings. Clinics make these needs visible and manageable rather than leaving younger adults to navigate complex systems alone. While the data demonstrates that specialized models of care improve the patient experience, the presence of some ongoing challenges suggests that these clinics may be operating under perhaps resource and capacity constraints, rather than, I think, reflecting limitations of the model itself. So in other words, the model works, and with proper resourcing, it could deliver even stronger outcomes. So care coordination was another area wherein striking differences between models of care were identified. In traditional settings, without access to specialized clinics, 51% of respondents reported coordinating their own care. So managing appointments, navigating providers, ensuring information flowed between services. This level of self-management during active cancer treatment is concerning. It increases stress, it risks gaps in communication, and it disproportionately impacts younger adults who may already be balancing young families, childcare responsibilities, early career pressures, and household roles. In contrast, for those who were treated in a specialized clinic, care coordination shifted back to the system. Only 18% of patients reported coordinating their own care. These clinics appear to substantially reduce the coordination burden on patients, replacing self-navigation with structured and clinic-led support. So we asked patients who did not have access to an AYA or early age onset clinic to reflect on their own experience and consider what difference a dedicated clinic, one with a coordinated team of healthcare professionals, could have made in their care. The responses were overwhelming. 45% reported they perceived it would have significantly improved their care and support, and another 41% said it would have somewhat improved their experience, reflecting really a system-level shortfall. Young adults, they know exactly where the gaps are: fragmented support, inconsistent navigation, limited psychosocial resources, and a lack of age-appropriate services. And they can see how coordinated models could have changed the trajectory of their cancer experience. These findings are compelling because it comes directly from the lived experience of young adult patients. They're telling us that there are many gaps in age-appropriate care for younger adults, and the concept of specialized clinics are perceived to improve care, reduce burden, and shape positive outcomes. And when roughly 6 out of 7 patients are saying that their care could have been better with access to a model that exists only in certain hospitals, only in certain healthcare facilities, that really becomes a national equity issue. And this is why expanding AYA and early age onset clinics across Canada is really an urgent policy and system priority to ensure that all younger adults receive the coordinated, comprehensive, and age-appropriate care that they deserve. So survivorship care is where the system gaps become most visible across both models of care. When we look at coordination between oncology, primary care, and other specialists, only 26% of respondents felt their post-treatment care was very or extremely supportive. When we look at social reintegration, that number is also quite low at 10%, and long-term side effect education, only 9% felt well supported. At the opposite end of the spectrum, 45 to 73% of respondents reported that survivorship supports were not at all or only slightly supportive across coordination, reintegration, and long-term health education. These patterns demonstrate a consistent gap in the transition from active treatment into survivorship. The gender differences amplify this concern. Only 13% of respondents identifying as female felt supported post-treatment, compared with 40% of those identified as male. And 88% of females reported that they did not feel informed about navigating life after treatment, compared with 60% of males. These disparities highlight systemic gender inequities, which plague really all aspects of healthcare delivery. When we asked about post-treatment challenges, patients identified 3 dominant concerns: emotional and mental health issues, persistent physical symptoms, and the absence of a clear survivorship care plan. This aligns with a critical system-wide gap. We had 79% of respondents reported that they did not receive a survivorship care plan at all. Notably, these deficits were reported across both respondent cohorts, indicating that survivorship is really a system-wide weakness rather than a clinic-specific issue. The qualitative data obtained through the survey provides a clear view of both the strengths as well as the persistent gaps within Canada's existing programs. On the left, patients highlighted several aspects they found most helpful. Coordination and notification of appointments stood out consistently. Patients also emphasized the importance of psychosocial and emotional supports, including access to social workers, talk therapy, spiritual counseling, and facilitated peer connection. Many credited referrals to specialized programs and mental health services as essential to their ability to manage treatment demands. On the right, however, patients also identified areas where additional support is required. The strongest theme was the need for earlier and more consistent access to psychosocial services. Several patients reported that a social worker or counselor should be involved immediately at diagnosis. Young parents specifically noted gaps in support for coordinated appointments while caring for children, and underserved communities highlighted inequities in culturally appropriate support. Survivorship, unsurprisingly, emerged as an area of particular concern. The qualitative responses from patients without access to AYA or early age onset program reveal consistent system-level gaps across navigation, information, psychosocial support, and coordinated care. A dominant theme is the absence of structured navigation. So patients described needing a single point of contact and reported acting as intermediaries between providers. Information deficits were also prominent. Patients noted they had to research all the programs themselves and highlighted the need for centralized resources. Psychosocial and family support needs were repeatedly reported to be unmet, with calls for family therapist support, grief counseling, and guidance on sexual health. Additional gaps included fertility services, financial guidance, and system management. Collectively, these findings indicate that in the absence of specialized programs, younger adults face fragmented care that does not address the unique needs of their phase of life, and they must self-navigate critical components of treatment and survivorship. And with that, it is my pleasure to hand it over to Philomena, who will take us through the survey limitations, implications, and the conclusion.
Thanks very much, Cassandra. I'm just going to quickly share my slides and kindly let me know if you see them okay.
Looks good, Phil.
Yes? All right.
Yes.
Here we go. All right. So thanks very much, ladies and gentlemen, for joining today. As we move into the final section of our presentation, I'd like to briefly review our survey limitations, reflect on the findings, implications for care delivery, and close with some key conclusions and calls to action for essentially helping to improve cancer care delivery for younger adults diagnosed with cancer in Canada. As with any patient-reported survey, there are several important limitations to acknowledge here. Firstly, certain tumor groups, particularly gastrointestinal and breast cancers, were overrepresented in the sample, which limits the generalizability of findings across all early age onset cancer tumor types. Secondly, while the overall sample size was quite robust, with which we were very pleased, geographic representation remained uneven. All provinces were represented, but 38% of respondents were from Ontario, and no responses were received from the territories. We also recognize the inherent challenges associated with retrospective self-reporting. Thirdly, it's worth noting that many respondents, both those with and without access to specialized young adult cancer clinics, received care in academic cancer centers or centers of excellence, which are inherently better resourced. These are centers that offer integrated multidisciplinary teams, supportive care services, and system navigation supports that are often absent in smaller community or rural settings. Consequently, the experiences captured in the survey may not necessarily reflect the needs or barriers faced by younger adults treated in under-resourced environments, where care is more generalized across age groups and specialized supports can definitely be limited. 4, despite providing definitions, variability in medical terminology and individual interpretation may have influenced how respondents understood certain questions. And with all retrospective patient surveys, the results are subject to responder and recall bias, and the sampling approach, largely through advocacy and support networks, may not capture the full spectrum of experiences among all young adults diagnosed with cancer in Canada. Taken together, these limitations underscore the need to interpret the findings with appropriate caution, while still recognizing the important insights they provide into the lived experiences of younger cancer patients across varied care contexts in Canada. So in summary, as we reflect upon objective number 1, the findings are quite clear, my friends. Across the entire cancer care pathway, younger adults consistently reported unmet clinical, psychosocial, and supportive care needs. These gaps persisted from treatment right through to survivorship, highlighting structural limitations in how age-appropriate care is delivered across Canada. These results point to several actionable opportunities. We need to strengthen system capacity to deliver age-appropriate care consistently and ensure routine psychosocial and supportive care assessments are built into standard practice. Care navigation must be improved. For many young adults, a cancer diagnosis is their first interaction with the healthcare system, and coordinating complex care while raising families, managing work or education, and financial pressures is simply too overwhelming without structured support. Communication must be clearer to enable informed decision-making. Furthermore, survivorship planning should begin much earlier in the care trajectory. This is what we're hearing. Collectively, these findings demonstrate that the needs of younger adults are both predictable and addressable, but the system is not yet configured to meet them reliably. Our second objective was to evaluate access to and experiences with specialized AYA and EAOC clinics. The findings reveal a significant structural gap. 83% of respondents had no access to a dedicated clinic or program, resulting in more fragmented care and higher unmet supportive care needs. Nearly half, 45%, of this group believed a clinic would have significantly improved their care, with another 41% believing access to a dedicated AYA or EAOC clinic could have somewhat improved their care. These are astounding numbers. Among the 17% of respondents who did have access, the care experience was notably different. Care was more coordinated. Navigation burdens were lower, and supportive care services were utilized more consistently, demonstrating the clear value of this model. These findings provide compelling evidence that specialized young adult cancer clinics or programs deliver a distinctly higher standard of coordinated, patient-centered, and age-appropriate care, affirming their importance as a core component of high-quality cancer care for younger adults. At the same time, persistent gaps within existing clinics, particularly in survivorship, they signal an opportunity to further strengthen, standardize, and sustainably resource these models, including exploring virtual components to extend access and consistency where in-person clinics are limited. Overall, the data points to two system priorities: expanding access to specialized AYA EAOC programs nationwide, and optimizing current models to ensure reliable, age-appropriate, multidisciplinary care across all cancer centers. These findings point clearly to where system-level improvements are most urgently needed. The following calls to action reflect the priority areas with the greatest potential to strengthen care, quality, and consistency for younger adults with cancer. First, expanding access to dedicated AYA, EAOC clinics, programs, or models of care across Canada and across tumor types is essential to reducing fragmented pathways and addressing the unmet needs consistently reported by younger adults in both the survey and in the literature. Second, implementing dedicated care coordinators or navigators at diagnosis to provide earlier, structured guidance, helping patients move through treatment and survivorship with greater clarity and support. Thirdly, supportive care services need to be integrated directly into standard care pathways with clear referral routes when services are external to ensure younger adults don't fall through gaps in care. And finally, establishing a centralized digital platform would offer a single, accessible hub for reliable AYA, EAOC information, resources, and connections, especially critical for provinces without dedicated programs. Together, these priorities chart a path forward to more reliable, age-appropriate cancer care nationwide. I can't say this enough, ladies and gentlemen. I want to extend a heartfelt thank you once again to our incredible patient group supporters who have been steadfast in their ongoing collaboration of this initiative and symposium. Your partnership makes this work possible. You are relentless champions of hope, and we are so grateful. Thank you for tuning into our early age onset cancer patient survey findings presentation. We are immensely grateful, and we welcome any questions or reflections from the audience.
Thank you, Philomena. So again, as Philomena said, we do invite our audience to submit questions or comments using the question bar below your video stream. We just have a couple of minutes here. I think I'll quickly address a question asking about what the N is, the letter N, and that N value is just representative of how many responses were obtained. And then another kind of, I'm not sure if it's a comment or a question, but a comment about why the survivorship care is lacking so greatly. And I'll start off, I think long-term survivorship is an issue that is so uniquely important to the early age onset cancer population who, in many cases still have decades of life to live following their treatment. And our system approaches to survivorship, they simply can't be the same for a patient in their 20s, in their 30s, or their 40s as they are for, perhaps a 70-year-old cancer survivor, which the systems are truly designed around. And as incidence continues to rise, we have more young patients diagnosed, and you couple that with maybe earlier detection, improved cancer treatments. The younger of young survivors that we're going to have is going to continue to grow, and our systems truly have some planning to do to be able to keep up. Philomena or Shalini, I don't know if you want to add to that at all.
That's really well put. And with our younger survivors, they actually end up experiencing secondary cancers. So the survivorship phase is critically important. And there are long-lasting effects that they end up experiencing that need to be addressed, but they have a tendency to suppress them and not address them. And those supportive care services are critically required during that phase because there's a tremendous amount of isolation and loneliness that they end up suppressing again and not addressing. And so I can't emphasize this enough. Survivorship, supportive care needs need to be addressed. I can't say that enough. I know we don't have very much time, Cassandra. Are there additional questions?
I think we're okay to end there, and we'll follow up with any others on a one-on-one basis. So just a reminder to our audience that you just may need to refresh your video stream between sessions, and we'll be right back with our patient group roundtable.
Okay, perfect.